Good afternoon, everyone. Thank you for joining the Bipartisan Policy Center for today's event, where we're very excited to release our latest brief titled State Long-Term Care Progress, a Blueprint for Federal Solutions. I'm Bill Hoagland, Senior Vice President here at the BPC. It's my pleasure to work with our health program here at the center. It's led by Marilyn Serafini, its Executive Director, and Lisa Harushian, who's our health program director, who led this particular project that we're releasing and report that we're releasing today. Over the past decade, our health program here at BPC has focused on enhancing care for older Americans and individuals with disabilities who depend on long-term services and support, LTSS. The nation's LTSS system, we all know, is complex. It's a patchwork of public and private payers, programs administered at the federal, state, and local levels, not to even to mention the 48 million family caregivers providing that care to their loved ones without compensation, I should say, often. All these services were estimated to cost nearly $500 billion in 2021, and I imagine are only expected to grow with an aging demographics. This year, listen up, this year, 2024, marks the beginning of the peak 65 zone. It's the largest surge of retirement age Americans turning 65 in our nation's history. Over 4.1 million Americans will turn 65 each year through 2027. That's nearly 11,000 every day. This baby boomer generation needs for accessible, high quality, and affordable LTSS services is increasing daily. However, despite the higher spending from both private and public sectors, the LTS system remains costly, fragmented, and often out of reach for many. We at BPC believe ensuring high-performing long-term care should be a priority for federal policymakers. While there's been some improvements at the state and federal levels, there's still much to be done to meet the growing demand effectively. In this brief, BPC analyzes data from the AARP's LTSS State Scorecards over the period from 2011 to 2023, and it's to identify areas for possible bipartisan federal reforms that would address persistent challenges to the system. I want to make clear that while BPC staff analyzed this extensive data from the scorecard, the policy positions from this brief are BPC's own and do not necessarily reflect those of AARP or the SCAN Foundation. As you hear today, states across the political spectrum are implementing very innovative practices and reforms to enhance their long-term care systems. These efforts present a valuable opportunity for federal policymakers to support state initiatives and apply these lessons at the national scale. I want to thank the panelists for their participation today, and I look forward to the discussion. I also want to acknowledge the hard work of the BPC staff, Lisa Harushian, who I mentioned earlier, but also the staff who contributed to this brief, Allison Buffett, Cameron Perry, and Aidan Kennedy. And finally, on behalf of BPC, I want to particularly thank the SCAN Foundation for their generous support for this work and this event. I'm now going to turn it over to Narda Apache, Vice President of Policy at the SCAN Foundation. Prior to coming to SCAN, Narda served on the U.S. Senate Aging Committee under the chairmanship of Robert Casey. She has very deep experience in health and aging policies. Thank you, Narda, and thank you once again for SCAN's support in this project. Narda?
Great. Thank you so much, Bill. And I also just want to thank the Bipartisan Policy Center for hosting this webinar, all of their work that has led to the report and the webinar today, and all of the speakers that share an interest and passion for this critically important topic. I also wanted to thank my SCAN Foundation colleague, Erin Westfall, who has been my partner in crime here on this effort. As Bill mentioned, my name is Narda Apache. I'm the Vice President of Policy here at the SCAN Foundation and have the honor and privilege of overseeing all of our policy efforts, which include both the state of California as well as the federal level. The SCAN Foundation actually recently, after I joined, underwent a new strategic planning process, refining our vision to advance a society where all of us can age well with purpose. And I'm proud that core to that strategy is continued commitment to a robust long-term care program that will enable all older adults, particularly older adults of color, those who are low income, and those in rural areas who have often been overlooked in policymaking, to be able to age in home and community. One of the first investments that the SCAN Foundation made in this space was the AARP LTSS Scorecard about 15 years ago. And I think today's discussion really provides us with an invaluable opportunity to both distill some of those findings, but look forward to learn from some of that state progress to inform federal policy. Since that initial investment, we have seen significant changes in how states have managed and administer their long-term care programs, and the changes that they've made to try and better meet the needs of older adults and people with disabilities. And we believe we're really at a unique point in time to explore bipartisan federal reforms to improve the nation's LTSS system, really with the goal of breaking down some of those silos that Bill mentioned, addressing those misperceptions and leveraging the opportunities to support everyone as they age. I also want to thank all of you here listening to this webinar today for your time, your expertise, and your commitment to improving our nation's health and aging system. With that, I'll turn it over to my colleague Brendan from AARP.
Sure. Thanks so much, Narda, and thanks to the whole team at the Bipartisan Policy Center for hosting today's webinar. My name is Brendan Flynn, and I am the Director of Long-Term Services and Supports with the AARP Public Policy Institute and a co-author of the 2023 Scorecard Report. With support from the SCAN Foundation, the Commonwealth Fund, and most recently the John A. Hartford Foundation, the AARP Long-Term Services and Supports State Scorecard Project has, since its first edition in 2011, gathered and analyzed a wide range of data sources to provide a one-of-a-kind comprehensive assessment of state LTSS system performance and provided each state a numeric ranking in comparison to one another. The fifth edition of the scorecard, published last year, includes more than 50 indicators organized into 5 dimensions: affordability and access, choice of setting and provider, quality and safety, support for family caregivers, and community integration. We also, for the first time, developed and used an equity-driven methodology for certain indicators to score and rank states with the concept of LTSS equity, or too often lack thereof, at the center. The scorecard and the information it includes offers an important tool for agencies and advocates at all levels of government, federal, state, and local. It brings value to consumers by providing information across the spectrum of LTSS, as well as key supports that facilitate access to these crucial services within and across states. Today's webinar drives an important conversation around the state of LTSS, and we are glad the scorecard could help inform this event and BPC's important work in this space. Thank you again to the whole BPC team and to the audience, and I now turn over the discussion to Judith Graham.
I'm Judith Graham. I write the Navigating Aging column for KFF Health News, which is an independent healthcare news service sponsored by KFF, a health policy and research organization that I'm sure everyone here knows. I've been a journalist for over 41 years, most of that time writing about the healthcare industry, and now I focus almost exclusively on aging. I'll be the moderator today, and my first task is to introduce our panelists, which I'm very delighted to do. Amber Christ is the Managing Director of Health at Justice and Aging, a nonprofit legal advocacy organization that fights senior poverty. I rely on the work of Justice and Aging often. Emily Rosenoff is the Director for the Division of LTSS Policy at the Assistant Secretary for Planning and Evaluation, which is the Principal Policy Advisor to the Department of Health and Human Services. We all know of their work in documenting the extent of need for long-term services and support in the older population. Regina Shi is a professor at Emory University's Rollins School of Public Health and a health policy partner at RAND, where her main research areas include aging, dementia, and caregiving, topics I write often about, dementia and caregiving. And finally, Wendy Fox Grage is the Senior Director for the National Academy of State Health Policy, a nonpartisan organization committed to developing and advancing state health policy solutions. We'll jump in just a minute, but I want to let you know that at the end of our panel conversation, we will take questions from the audience. So you can submit questions throughout the discussion by using live chat on YouTube or on X, formerly known as Twitter, using the hashtag BPC Live site. So let's start with talking about what LTSS, long-term services and support, are. Emily, can you provide a high-level overview of LTSS? What are we talking about? Who receives these services? And how are they funded and administered?
Yeah, so I'll just give a high-level overview. I know that there's a lot of folks on this webinar who may have various backgrounds. So just to level set, individuals with disabilities and older adults may need LTSS to help them function. As people age, they are at increasing risk for functional and/or cognitive impairments. And over time, they may need assistance with activities of daily living, or ADLs, or some sort of supervision because of their cognitive impairment. Long-term care involves a variety of services designed to meet a person's health or personal care needs. These services help people live as independently and as safely as possible when they can no longer perform everyday activities on their own. 70% of adults who survive to age 65 develop severe LTSS needs before they die, and 48% receive some paid care over their lifetime. Only 24% of older adults receive more than 2 years of paid LTSS care, and only 15% spend more than 2 years in a nursing home. However, the lifetime risk of receiving paid care is not evenly distributed across the population. Lengthy spells of severe LTSS needs and paid care are much more common among older adults with few financial resources than their wealthy counterparts. Many older adults with severe LTSS needs rely exclusively on family and unpaid caregivers, and most paid care episodes are relatively short. So what do we mean when we say LTSS, or what do we mean by when we say the LTSS system? As Bill said at the top, it's less of a system than a patchwork of services, settings, payers, and programs. Most people want to stay in their home as they age. We can arrange for home and community-based services, or HCBS, to help support them. HCBS can include personal care, such as assistance with activities of daily living, transportation, case management, among other services. Outside the home, there are a few models. One is called adult foster care, where individuals needing assistance might live in a home with other unrelated individuals who can provide care. And then there are more facility-based models, such as assisted living or residential care and nursing facilities. Each of these settings have different payers and different regulations. Assisted living is predominantly private pay and is regulated at the state level. Nursing facilities, because they receive federal funding through Medicare and Medicaid, have federal regulations. When we say nursing homes, we typically mean places that provide both long-term care, nursing facility care funded by Medicaid, as well as provide some skilled nursing facility care, or SNF beds, that provide post-acute care to individuals who have had a hospitalization and who now need post-acute care. Think of the care that an individual might need after a hip replacement. So Medicare does not provide long-term care per se, but because of the funding for SNF care, Medicare policy has a lot of impact on nursing homes. Medicaid is a joint federal-state program. There are mandatory services that every state Medicaid agency needs to provide. For example, a state Medicaid program must cover inpatient and outpatient hospital services, physician visits, and they must cover nursing facility services. So these institutional long-term care services is something that all Medicaid programs must cover for individuals meeting the financial eligibility and who meet the medical necessity criteria for nursing facility services. There are also several optional benefits that states can choose to cover. Home and community-based services are an option of every state Medicaid program, although all 50 states provide some HCBS. states can choose to cover HCBS in several different ways. They can either choose to cover such services through their state plan, which would be open to all beneficiaries who qualify, or they can cover such services through other options, which might cap the total number of beneficiaries who can access such services. And I think Wendy will tell you more about these state choices in a bit.
Thank you so much. If there's anything takeaway, it's that it's very complicated. Wendy, we're going to move on to you. Tell us about how state systems for long-term services and support can look different from one another, how much flexibility they have in the design and administration of these programs, particularly Medicaid programs.
Sure. Well, first of all, thanks so much to the BPC for having me and for having this program. And I just really respect all the panelists on this call. So thank you to that. Okay, Judith, you're absolutely right. Oh my gosh, this is so complex, right? And it's complicated. And I'm going to make it even more so because every single state's doing something different, right? And as you said, the states really are kind of the drivers here. They have a lot of authority over long-term care, and they have budgetary, legislative, licensure, certification, regulatory authorities. They make lots of decisions with contracts. They make programmatic decisions and procedural decisions. And so all of those things really impact our long-term care system in every state. So I'll just give a few quick examples. Emily did a really nice job. So just a couple of things on the budget. Well, the states hold the purse strings to the state funding for these programs. Legislation, I worked for the National Conference of State Legislatures for 10 years and was very busy tracking all of the legislation which impacts the whole delivery system and then some. States are also in charge of licensure, certification, and regulation of all healthcare and long-term services and supports providers. Emily did a really nice job of talking about the Medicaid program and how complex that is. And she mentioned, for example, home and community-based services. Well, all of the states have waivers. And then even within those waivers, states can decide which Medicaid populations get these services, which of these optional home community-based services are covered, and even if those services are capped and even where they're delivered. So, and then in contracts, again, huge variation and authorities there. For example, Medicaid contracting with managed care plans and others. So because of all of those budgetary, policy, programmatic decisions that states make, that's why you have all those wide variations across all of those indicators in that long-term scorecard that Brendan was discussing. And even in the new BPC report, that's why you're seeing all of those changes. Or variations. It's reflective of all those different decisions that states make.
Thank you so much, Wendy. As for, if it's hard for those of us who are immersed in this to understand, imagine a family, an older adult becomes sick, needs rehab care, needs to be placed in a long-term care facility. They don't know anything about state regulations. They don't understand Medicaid. They don't understand Medicare. They don't know where to go for help. Amber, can you help bring us home to the consumer side of this? As the baby boomers age into retirement and beyond, the demand for long-term care is going to grow enormously, but many people can't afford to pay outside of just not understanding what options are available to them. Can you talk about some of the barriers that consumers face?
Yeah, thank you. And thank you for having me on this panel. So yeah, the need for long-term care is growing and will continue to grow. And right now our long-term care, well, I don't want to call it system, but what we have in place can't meet the need we have now, much less the growing need. And of course, as you noted, Judith, is one major obstacle to long-term care is cost. And today our current long-term care system is primarily financed and delivered through Medicaid. But Medicaid has exceedingly low income and resource limits and strict eligibility rules. And those rules keep low income people who are eligible for the program in poverty. And then it forces people who need long-term care into poverty in order to access the program. And for many, many others, the Medicaid eligibility limits and rules keep them out of the program altogether. And these might be individuals who are $1 over the income limit or $50 over an income limit and then cannot access Medicaid. These individuals, they're often called, are referred to as the missing middle or the forgotten middle. But I just want to say that that middle is really broad and includes a very large group of people, not homogeneous, with incomes that are really low and resources that are really low. Most older adults and people with disabilities do not have a lot of income and resources. And they demographically look very similar to the Medicaid population, but just with a little bit more income and resources. So I think that really speaks to how punitive our Medicaid eligibility rules are for people who need long-term care, and the need to expand Medicaid eligibility rules, like the eligibility expansions we've seen recently in states like California and New York. But what are the options for people who do not qualify for Medicaid? And it's just really limited and difficult. I think we talked a little bit about Medicare. It does have some coverage of long-term care in an institutional setting, and it does have a home health benefit. But due to a whole bunch of problems that I'm not going to get into today, people aren't able to use that benefit to the extent that it's theoretically available under the law. So people are left paying out of pocket and making really hard financial decisions month to month on what they can afford. And many people have to rely on the family caregivers to fill in the gaps to provide support unpaid. And this just has huge ramifications on caregivers who are more likely to be women and women of color. They have to take time out of the paid workforce and reduce their hours to provide care. That harms them like in the short term economically, but it also harms them long-term economically in that they're not paying into Social Security or retirement, and it makes them much more likely to age into poverty. So our lack of an affordable long-term care system harms those who need the care. It harms those who are subsidizing the system by paying for that care unpaid or providing that care unpaid. And it harms society by perpetuating intergenerational poverty. But I think another point, Judith, that you were making is that cost isn't the only barrier, right? That's a threshold barrier. Coverage is a threshold barrier, but we also see other barriers to accessing services. Even if you have Medicaid for coverage. For example, because it's an optional benefit to get at-home care under the Medicaid program, we see wide variation from state to state in what people can access and how quickly. So if you live in Washington, D.C., you might get care right away. But if you cross over the state line into Maryland, you're going to have to wait months or even years for services. And we also see disparities based on race and age and disability and other demographic factors, which I know Dr. Shi is going to discuss more. But I think one statistic that stands out to me again and again in our work is the one about Alzheimer's and dementia, that at age 80, 75% of people with dementia are living in a nursing facility, compared to 4% of people at age 80. And that is a failure of our long-term care system. That is a failure of people with Alzheimer's and dementia and their families. These are individuals with lives and connections who are separated from their families and from their communities. They're family caregivers who face years of impossible emotional and economic choices. So even if you can pay for care through coverage, there are just still huge barriers to accessing that care that must be considered in developing and improving a long-term care system that works for everyone.
Thank you, Amber. I appreciate those remarks very much. You mentioned, Regina, I'm going to turn to you to expand on the disparities, both racial and ethnic, economic, and geographic, that affect how people can access long-term services and support, and what's known about that.
Yes, thank you, Judith. And thank you also to BPC and SCAN Foundation for having me here. So unfortunately, the data continue to highlight stark disparities in the access and quality of long-term services and supports for underrepresented and minoritized groups. These populations include people who are Indigenous, African American, Hispanic, and individuals with limited English proficiency. So these are often minoritized individuals that are younger, have greater physical impairments, and are more likely to use facility-based care like nursing homes. And when they do use nursing home care, racial and ethnic minorities receive care in lower performing nursing homes than their white peers. They often have untreated pain, more feeding tube use, and antipsychotic medications. On the other side, with home and community-based services, which is where my research focuses on, my research colleagues and I have found that there are enormous barriers to access for rural populations. This includes limited availability of long-term services and supports providers, inadequate transportation services. These providers often say they have threats to their ability to stay in business, and they often experience challenges to recruiting and retaining direct care workers in rural areas. In addition to these access challenges, there are quality of care challenges. The quality of care is lower, and the likelihood for avoidable hospitalizations is higher for racial and ethnic minority consumers compared to their white peers. So there's this conundrum that we've identified when we speak to Medicaid home and community-based providers and policymakers. They say that they perceive that rural individuals rely more on family caregivers, and that could be either a cultural preference or a compensation for the dearth of home and community-based services in rural areas, or a combination of those factors. So it can feel a little bit like circular reasoning, where the spatial isolation of beneficiaries may be fueling the perception that there's a lack of demand, which then reduces the rationale for funding new services. So these challenges of unmet needs and lower quality of care among rural communities and communities of color are leading to soaring costs to the healthcare system. And this is because of things like falls, emergency department visits, and hospitalizations. And as we alluded to earlier, it also drives a continued reliance on family caregivers who continue to be an under-recognized backbone of our long-term services and support system. Many people cite that the single largest payer of long-term services and supports is Medicaid, but family caregivers actually provide the majority of care, and they bear an enormous social and financial burden, as this unpaid work has been valued at an estimated $600 billion, according to AARP.
Thank you so much for those perspectives. So we've talked about many of the problems in affordability and access for long-term services and supports. And yet we have been making progress over the past 10 years. Let's move on to some of what we are learning at the state and national level. Emily, I'm going to kick it to you. At a national level, what are some of the improvements in LTSS we've seen in the past decade, and how have policy reforms contributed to those improvements?
Yeah, there's been a lot of activities over the last 2 decades to help shift from a reliance on institutional settings to deliver long-term care to making the community-based care easier to access. First, states have expanded the scope and number of individuals eligible for HCBS over the years. You can see the trends over time, with now more than 50% of Medicaid long-term care spending going towards HCBS over institutional care. One example of a program that has supported that effort was the Medicaid Money Follows the Person demonstration program. Since 2007, 45 states and DC have gotten grants to plan and implement their Money Follows the Person programs. So this program helps support individuals who've been residing in an institution for more than 6 months to transition back into the community. Under the Money Follows the Person demonstration, states could develop and implement innovative approaches to enhance comprehensive transition coordination services to change their long-term care systems. However, when Money Follows the Person was launched, it soon became obvious that it wasn't enough just to have supportive services for individuals to move into the community. Individuals could not move unless there was affordable, accessible housing as well. For most people, once they have transitioned to an institution, they no longer have a home to go back to. And so that really, I would say, redoubled our work with HUD in order to see how we could better collaborate on our shared beneficiaries. In addition, there have been program refinements. For example, in 2022, CMS provided guidance on MFP that expanded the definition of supplemental services that can support an individual's transition from an institution to a community, including short-term housing and food assistance. These changes helped to address barriers to community transition for eligible individuals in institution and increased transition rates. In addition, in recent years, CMS has provided greater flexibility to states through 1115 research and demonstration waivers. These research and demonstration waivers allow states to test new program administration in their Medicaid program, as long as such program changes are expected to be budget neutral. For example, in November 2023, CMS released guidance on health-related social needs and 1115 opportunities for states under that authority. The guidance outlined how states could help enrollees stay connected to coverage and access needed healthcare services by addressing unmet health-related social needs. As these program refinements have been occurring, we've been working hand in hand with our partners at HUD. Our partnership and collaborations with our colleagues at HUD is stronger than ever. For example, in 2022, we launched the HHS and HUD Housing and Services Resource Center. This includes several HHS agencies, and it's a collaboration to bring together HHS and HUD resources and TA into one central spot. It provides TA, webinars, and guidance for really how you blend and braid housing and services together. As part of that partnership, we have recently launched the Housing and Services Partnership Accelerator. This will provide 12 months of intensive TA to 8 states and DC. These states all cover some sort of health-related social need and are working to better serve their beneficiaries, either transitioning from institutions or who are experiencing chronic homelessness. And just last week, CMS released the Medicaid Access Rule, which further strengthens state Medicaid HCBS systems. So with that, I'll turn it over to others.
Thank you. Wendy, can you give us a sense of what's going on at the state level and how the innovations that have been occurring over the past decade at that level and what they imply for the future of LTSS?
Sure, I'm happy to. And in fact, I'm going to even make the time frame shorter because I don't think we can answer this question unless we talk about the COVID pandemic and its impact on the long-term services and support system. And you all mentioned family caregivers and families as well on this. So as a result of that, we have seen numerous things that states have made innovations in just recent years. You've seen more states increase the number of folks who can self-direct or consumer direction type programs. We've seen much greater use of more of the electronic and virtual type platforms, especially with assessments and other things that can be done virtually that really helps folks. I don't think we can even talk about this without talking about the workforce and the direct care workforce. Those are home care aides, personal care aides, certified nursing assistants. We had a shortage before COVID, and it just really heightened it. And so you're seeing states at a level I had never seen before. I've been in this, I've been doing this work for over 30 years. I think there is more momentum and energy in states to address wages, which we know have been low, and recruitment as well as retention efforts, retaining those workers. Many of you on this panel have mentioned family caregivers. Again, I think we've seen quite a bit of momentum with the COVID pandemic. We saw how reliant we truly are on family caregivers for long-term care and in healthcare. And huge momentum at both federal, state, local, all levels. There is now a national strategy to support family caregivers, and there's incredible momentum at the states realizing that they need better supports. And then finally, I don't think we can talk about COVID and not talk about the tragedies that happened in nursing homes and now state efforts to make reforms in that area to improve the quality of care and quality of life.
And what about assisted living? Can you address how COVID affected state regulation of assisted living and efforts there?
Yeah, I'm glad you brought that up. I was trying to make my comments really short to get in a certain time frame to give the other panelists time. Yes, and in fact, that's such a big area that we have we are in the midst of planning our big annual conference for state health policymakers, and that is one of the sessions we are going to be focusing on. We're going to have a session dedicated to assisted living regulation and financing. So again, lots of changes there as well.
Thank you, Wendy. Regina, I'd like to ask you to talk more about what does it mean to integrate people in the community who are receiving long-term services and supports, and how can state initiatives inform federal reforms to improve community integration?
Yeah, thanks for the question. So community integration in the LTSS system means the ability to access a range of non-medical social drivers of health. So this means things like transportation, housing, and food. Without these kinds of social services, older adults cannot age in place. So I often emphasize the word home. You cannot access home-based services without stable housing. You cannot access community-based services without an age-friendly community. And so programs that facilitate community integration are those that are things like an age-equitable transportation system or an age-friendly health system, and home and community-based services that can facilitate successful discharge from a post-acute care setting to home or community. Another way to ensure accountability in implementing these comprehensive community supports is a multi-sectoral plan on aging. A multi-sector plan on aging is like a blueprint, a long-term blueprint that can guide state and local policy choices, how they fund these programs, and the programs that facilitate community aging so that people can age with dignity in the setting of their choice. These multi-sector plans on aging are driven by state governments, usually also in partnership with local communities and private organizations, research entities, and philanthropy. To date, there are states that have or are working to develop a multi-sector plan for aging, and they've been working on things like addressing equity, using a person-centered lens, and viewing aging as a lifespan phenomenon. One key hallmark is that these multi-sector plans on aging develop cross-sector collaborations to develop innovative solutions. So working across health, human services, housing, transportation, and employment. There are about 8 states with plans that are or are developing plans, but the United States does not have a national plan for aging yet. If such a plan were to exist, it could galvanize efforts to support all states in adapting or tailoring their own plans without stifling state innovations, and then also set key metrics or indicators of success to measure progress towards those goals via data dashboards.
Thank you so much, Regina. Next to you, Amber, all of us know that it's one thing to look at policies and reforms imposed from the top down. We also need to be looking from the bottom up and talking to the people who are actually receiving services, whether it be older adults themselves or their caregivers. How can we make sure their voices are prioritized as states and the federal government pursue long-term services and supports reforms, and what might that look like?
Yeah, thank you. I think our discussion on disparities in who has access to long-term services and supports demonstrates just how essential it is to ensure policymakers hear from older adults and people with disabilities and their caregivers. And it really does mean including their voices throughout the development of a policy, and even more importantly, in the implementation of those policies. And that's just not an easy lift. It is far easier for policymakers to set out and have a discussion among themselves and bring in a handful of experts like us to develop a policy. But it takes a lot more resources and time and intention to listen to and incorporate the feedback from those who have the direct experience with the long-term care system. It also takes humility. We kind of all want to think of ourselves as knowing best, especially as experts and decision makers. But that kind of shortcut is how really the status quo gets maintained, and how bias and discrimination and unfairness gets baked into policies time and time again. So we need dedicated resources and intention, and we've seen this work. As Wendy just noted, the Family Caregivers Act Advisory Council that developed the national strategy to support family caregivers is one way we saw the voices of people impacted by the system get incorporated into policy solutions. There are other great federal models like the Community Living Equity Center, which is conducting research on community living through one-on-one conversations and focus groups. Wendy also just mentioned the Direct Care Workforce Strategy Center, mentioned the Direct Care Workforce, and there's the Direct Care Workforce Strategy Center, and they've developed an advisory council to get those who are impacted, including those who receive care, but also workforce and workers involved. And at the state level, we see this happening across states with the formation of advisory groups and focus groups. And as Regina noted, in those multi-sector plans for aging, all of them have advisory groups of some sort. Again, though, this type of outreach and engagement requires time and dedicated resources to ensure broad representation and engagement. I also think that there's a real role for media and storytelling generally, both at the national level and particularly at the local and state level, uplifting the voices of older adults and people with disabilities in those stories. And of course, their caregivers too. But I think it's really essential that the people who need the care are included in the story, which again is not easy, but it is so essential in showing their experience with the system and their humanity. Wendy mentioned the pandemic, and I think that this really became incredibly acute during the pandemic, but just generally overarching, a pervasive issue we face in improving our long-term care system is that as we as a society devalue the lives of aging and disabled people. So as experts and people who care deeply about improving the long-term care system, we have to commit to prioritizing the voices and incorporating the voices of those who need LTSS and use the system into the policies and into the work.
And one example of that during the pandemic were the policies that prohibited family members and family caregivers from visiting people in long-term care facilities. And it was only when their voices were raised that we became aware of how essential that was. As essential as keeping them safe from COVID was keeping them connected to the people who care about them and who they rely upon and who give them a sense of meaning and purpose in life. Emily, I'm going to close off the panel with you, but first let me ask our audience members to send in your questions. We're close to the time that we'll be able to address those. I see a couple. Please feel free to send in more. Emily, last question for the panel. So the BPC's analysis identified strong bipartisan support for reforms that address the shortage of direct care workers and recognized how some states have used investments from the American Rescue Plan Act to address this shortage. Looking ahead, why is it important to grow this workforce and learn from states' approaches?
Yeah, thanks for the question. Over this panel, we talked a lot about the long-term care workforce or alluded to it, but you can't put too fine a point on it that the bulk of long-term care is really provided by hands-on care that's either formal and paid caregivers or informal from family and friends. And so without the access to those workers, you just can't have a long-term care system. And high quality long-term care depends on the availability of this workforce. With the current demographic trends, we know that the demand for these workers is expected to continue to grow to nearly 6 million new jobs over the next decade as the population ages and more people seek HCBS. Home health aides and personal care attendants will experience the largest increase in new jobs of any occupation between 2022 and 2023. Many of these workers left their jobs during the COVID-19 pandemic, which further exacerbated the shortage of workers to meet demand. And despite increasing demand, the jobs can be difficult. These are physically taxing jobs, often with part-time hours, unpredictable schedules, wages lower than other comparable jobs, limited access to training, and high rates of injury. As a result, job turnover is high, recruitment and retention is challenging for both families and service providers, and people can often not get the care they need due to lack of workers. President Biden committed to ensuring high-quality jobs by signing an executive order in April 2023 to increase support for the paid HCBS workforce who provide this care and assistance. The executive order had a number of provisions to strengthen the caregiving workforce. Among them was among the many provisions was one that challenged DOL, Department of Labor, and HHS to really examine the workforce data infrastructure. And recently, DOL and HHS released an issue brief on improving the data on the workforce delivery of HCBS services, which really summarizes some key recommendations. And one key thing is that we need to enhance consistent and systematic state data collection efforts to really inform evidence-based practices on HCBS workforce. Wendy alluded to the AARP funding that states have given to shore up the HCBS workforce, but we really do need more data to see how these investments worked and how effective they were. So for example, some states raised wages a bit, some states put investments in training. There were many things we did that states tried, and without adequate data, we really can't understand how they were implemented and how effective they were. And then there's also opportunities for states to learn from one another and to share these evidence-informed practices and improve state-based workforce data collection. On a related note, as I mentioned earlier, last week with the Medicaid or CMS publishing the Medicaid access rule, there were a number of provisions to strengthen the HCBS workforce, but among them was a provision that at least 80% of Medicaid payments for HCBS need to go to homemaker, home health aide, or personal care aides towards the compensation for these direct care workers as opposed to administrative overhead. So the changes in the Medicaid access rule will further improve access to HCBS for Medicaid beneficiaries and further strengthen the HCBS workforce. With that, I'll go back to Judith.
Thank you. Our panel now is officially over, and we're going to take questions from the audience. A couple have come in. We encourage you to submit more. From Laura, a question. We haven't talked about technology. And her question is, how are technologies and related services incorporated into long-term care? I would add, how can they be incorporated into long-term care as we look to expand the reach and access to services? Regina, you want to offer some preliminary thoughts?
Sure, and would welcome other thoughts as well. So there are a variety of technology solutions and applications that can help with administering long-term services and supports. So these are things like sensing or monitoring technologies. You can think of, assistive technology. There are also platforms to administer telemedicine and also mobile devices that can enhance people's ability to move about their lives and improve their quality of life when they have activities of daily living limitations. There are also ways for technology to be used to support family caregivers in providing care to people with disabilities and older adults. I think the challenge with administering technology and harnessing the full power of assistive technology is, one, awareness of these tools, affordability, and then access to them. Many communities do not have stable internet or broadband access. And so we are limited in our ability to make full use of assistive technology and these devices without equitable access to internet. I also would love to make a plug that family caregivers are so integral in delivering LTSS in collaboration with formal providers. EHRs is technology, and if we can tag family caregivers as part of the care team, that would go a long way to ensuring smooth transitions in care and high quality long-term services and supports.
Anyone else want to weigh in on the technology side? If not, we can move on to the next question. Oh, I'll add that, a very positive development is the availability of training programs for family caregivers online, physical therapy, speech therapy, occupational therapy programs online, dementia care programs that have gone online that educate family caregivers about caregiving, but we need families to be able to afford the technologies and be able to use these technologies. They hold enormous potential, but some of it unrealized. Wendy, I'm going to flip this one to you. It's about managed long-term services and supports, and it's from somebody in Minnesota, and the question is an interesting question. Should people be able to buy into, even if they don't meet the eligibility standards for Medicaid, buy into programs of the sort that are available in Minnesota?
So I'm aware of the program in Minnesota with their Medicaid managed care, long-term care program that they've had for a really long time. That is a leader, and we've been working with them as well. I was reading that question a little bit differently, and that is kind of that managed care, that long-term care, kind of the answer. I think it could be in some states. I also, though, think in terms of what, Amber was talking about, kind of the folks in the middle class, right? It's a big middle. Is that going to be the answer? I don't think there's any one answer to that. And unfortunately, I don't think that is the answer for coverage of that entire group. There are some states that have programs that have eligibility that is more generous than the Medicaid program, that allow people to get some of those home and community-based services that both Regina and Emily were talking about. But I don't think that is going to be kind of the answer to it, right? And that is one of the toughest things that I think all of us were kind of dancing around, and that is, how do you pay for long-term services and supports, right? I mean, that is the big answer, and I do think that's a federal, state, private solution that's broader than that model in Minnesota. But welcome others to weigh in on that as well.
Key question: how are we going to pay for this, and how are we going to figure out how we're going to pay for it? The BPC report suggests creating another national commission on long-term care to study this as well as other issues. What are your thoughts? Who wants to jump in on how we pay for this? Oh, it's a red hot topic. Nobody wants to put their, okay. Let's move on to something else. It's obviously the big, the elephant in the room. There's a question about state plans, multi-sector plans for aging. Amber, I wonder, you're in a state that has this kind of plan. Can you just give a sense of what it looks like and what potential it has? I guess there are 8 states with plans, and there are multiple other states that are creating plans. What do you see as the potential of these plans?
Yeah, and I'm actually in 2 states that have plans. So I previously lived in California when it kicked off its planning process around their plan, and now I live in Missouri, actually, and they have their own planning process that's happening. And I just wanted to flag that this is a very complicated name that doesn't make any sense, but it's the Interagency Coordinating Committee on Healthy Aging and Age-Friendly Communities. They are talking about what Regina was talking about, this federal planning, to have a kind of a federal model that then can kick off that state momentum in states that aren't currently have plans in place. I actually think that these plans are such an important vehicle across all aging and disability services, can be an important vehicle. But when it comes to long-term services and supports, in California, for example, there was a dedicated long-term services and support subcommittee of their plan that came up with a number of recommendations on how to start to fill in the gaps of the long-term care system. And I think what Wendy was getting at is that there isn't just one solution here, right? I mean, ideally there would be, like, we would have some federal payer that's long-term care for all, but that's not where we're at. And so what are the different policies that can start to fill in those gaps and not perpetuate any of the disparities we're seeing in the current system, and actually addressing those disparities instead? And so I think these plans are just a perfect vehicle for that. And it gets a commitment from the leadership in the state to those policies that are in those plans. And so I really encourage folks to get engaged in their planning processes, or if they're in a state that doesn't have a plan, to get involved in the encouraging their state governments to get a plan in place.
We have a question from Lucy, which she writes, what is needed to ensure quality and safety in long-term care facilities? I would add to that, what is needed to ensure quality and safety in services delivered at home? Who wants to take that on?
So how about I just jump in for the first part and I'll let other people chime in. So one thing I should raise is that earlier this spring, CMS released the first minimum nurse and nurse aide staffing requirements for nursing homes. And I won't comment on them because many other people have commented on them, but that is definitely a start for ensuring minimum quality and safety in nursing homes. Second, I've mentioned the Medicaid access rule, and that does require more reporting and quality measures in HCBS settings. So that is a foundational piece for both institutional and HCBS settings. And I'm sure others on this panel have comments on the rest of on those policies.
I'm happy to hop in here too. So obviously, Emily, staffing, right? Having staff, key as well. And then Amber talked about this, and it's getting the lived voice. It's hearing, especially in facilities, well, and even in home community-based services, right? Like hearing from the families, having a feedback loop, and the person receiving services. And even before even all of that, do they have the information they need to make a decision about what best fits what's going to work best for them, right? So even before that, then there's all sorts of things on the quality monitoring, especially in facilities with, surveys. And we talked about Minnesota a little while ago. They have a nursing home dashboard. So I think there's a variety of things from the get-go. And then the original question I know was about, in facilities, but do those folks even know about the different home and community-based options? And is the facility even the right path to go? So anyway, lots to unpack there.
Right. I think we're near the end here. I'd like to say something about the voices of consumers. We can't underestimate how emotionally charged these issues are for families. The decision to put a loved one in a facility is the hardest decision that families routinely say that, one of the hardest decisions they'll ever make. And caring for people at home, especially as they become very seriously ill with cognitive impairment, is an incredibly emotionally draining, emotionally taxing experience. So this is not just about this affects every family in America, what we're talking about, and certainly will in the years ahead as the baby boomers age, which is why this report is so important, and this panel discussion has been so important. I wanted to thank the SCAN Foundation and the Bipartisan Policy Center and the speakers, audience members who have submitted questions, and just say in closing that I think there is hope. I go back to what you said, Wendy, that the level of interest in this issue is at a point where it's never been before, I think, because people are experiencing this with their aging parents, because people of my generation are all getting older and facing decisions about who will take care of me, how, under what circumstances. We cannot underestimate, but the good news is there's been a lot of progress, and there's a lot of bipartisan interest and experience that we can draw on. And I think that's what this panel, this webinar has made clear. So thanks to all who came. I'm a little bit early, but I think I've said what my takeaway is from this panel. So thank you again, everyone.
Thank you.